Anoek is, well, she did her PhD in the lab of Jacob Valbrinen, where she actually learned intravital imaging and surgery also, which we haven't seen in Roberto's talk, which is something that we can discuss later. So implementing imaging windows, which is, of course, very useful when you want to do intravital imaging. And she actually used this technique quite nicely for studying extracellular vesicle transfer. And I think this is what she will mostly talk about today. She recently, or recently not that recent, but she then joined the lab of Joanna Joyce in Switzerland, further like working on using intravital imaging to look at therapy response in tumor progression. But I think she will mostly talk about the first part of her career. So thanks a lot for joining, Anoek, and looking forward to your talk.
Yeah, thanks for the nice, kind introduction. Voila. Yeah, so first of all, we'd like to thank the organizers for setting up this super nice intravital imaging seminar series. We'll see from the poll what the results are, but I personally, I would really like to continue either an in-person meeting or have a seminar series like this. Yeah, so as Jackie already announced, today I will mainly talk about intravital imaging and how I've been using this technique during tumor growth and metastasis formation. So as you may all know, tumors are extremely heterogeneous, and it's the individual cell that is important. So for example, from the billions of tumor cells in this primary tumor, it's often only a couple of cells that form distant metastases. But from static images like this, it's hard to predict the cells that form these distant metastases. So what we prefer to do is to visualize those individual cells that are able to do this. And we can obviously do this by using fluorescent mouse models in which different components of the tumor, so tumor cells, but also, for example, the tumor microenvironment, can be labeled with different fluorescent labels. And then to obtain visual access to these tumors, we implant these so-called imaging windows. And as you can see, the mice are doing fine with these imaging windows. So the mice are then being imaged on a 2-photon microscope. And just to give you a couple of examples of the things that we can see, we can visualize different mechanisms or processes that happen along the metastatic cascade. For example, here we can visualize the invasion of tumor cells labeled in green over a time course of approximately 4 hours into the surrounding matrix, surrounding stroma depicted here in black. But we can also visualize the tumor cells, again labeled in green, in the circulation, here depicted in red, and the blood vessels are then surrounded by collagens. But of course, not all these cells are able to form distant metastases. So that's also something that we would like to visualize. So, and in this case, we can visualize the arrival of individual tumor cells in the spleen or in the liver. And we can follow their outgrowth at the exact same spot in the liver over time. But how can we gain visual access to the tumors that we want to study? Well, one way, of course, is to create or to make a surgical excision. However, as you can imagine, this is a quite invasive procedure, and because of that, the tissue can dehydrate over a couple of hours. And in general, this limits the imaging time up to approximately 3 hours. And that's why these imaging windows were invented, which basically are titanium rings with a cover slip glued on top and with a groove on the side where the skin is then placed inside. So there are different imaging windows. So for example, this memory imaging window can be used to study either healthy mammary gland development, but also, of course, breast tumors. The dorsal skin fold chamber has been used to mainly study skin tumors. The cranial imaging window to use brain tumors, including gliomas. And the abdominal imaging window, which was developed in Jaco's lab, has been used to study multiple organs in the abdomen. Well, the implantation of this imaging window is quite nicely described in this Nature Protocols paper here. But just to guide you through, So first you make an incision through the skin, then through the peritoneum. Then, of course, you need to position the organ of interest into the incision site. Then you place a suture through the skin. You place the imaging window in with its groove into the skin and into the peritoneum. You pull the suture and the window falls nicely into the skin and into the peritoneum. And you can imagine that in this way, we really create a closed system that allows imaging for multiple weeks, depending on the imaging window. So the abdominal imaging window can be placed basically on all abdominal organs, including the liver, spleen, pancreas, colon, small intestine, and also the kidney. And as I mentioned before, because this now is a closed system, it allows to repeatedly image the mice for up to several weeks, which is shown over here for the different abdominal organs. I also have to say that in my current postdoc lab, I'm mainly using cranial imaging windows, and because this is quite a different system, it's not inserted into the skin. These imaging windows can stay in much longer, up to a couple of months, allowing you even to study the mice longer. But the rest of the talk, I will mainly talk about a project that I worked on during my PhD in the lab of Professor Jacob van Renen. At that time, still a PI at the Ludwig Institute in the Netherlands, but recently he moved to the Netherlands Cancer Institute in Amsterdam. And the focus of my PhD project was to study the transfer of extracellular vesicles between tumor cells. So the project started with an intravital imaging, with an observation that we made during intravital imaging. So in green, you see breast tumor cells. In addition to this observed migration behavior of these cells, we observed the release of these extracellular vesicles. And we were wondering whether the extracellular vesicles have a function in the observed migration behavior. So to investigate this vesicle release even a bit better, we differentially fluorescently labeled individual tumor cells from their surrounding tumor cells. And indeed, in multiple instances, we could observe the release of these extracellular vesicles. Of course, then we wanted to know what is the potential function of these vesicles, what is inside the vesicles. So we isolated the vesicles and the cells from these tumors. And we indeed, by electron microscopy analysis and by nanosite analysis, we could see that we successfully isolated extracellular vesicles. And we wondered about their cargo. And since in vitro experiments, it had been already shown that extracellular vesicles can carry messenger RNAs that can be functionally transferred to recipient cells, we performed a gene expression analysis of vesicles compared to whole cells. And we found approximately 200 messenger RNAs that are enriched in vesicles compared to cells. And when we then performed a gene ontology analysis, we observed many pathways that are involved in cell migration and cell motility. Then thinking of the idea that tumors are really heterogeneous and that it is often a couple of tumor cells that are highly migratory and metastatic, we were wondering whether it can be that these highly migratory cells release vesicles with messenger RNAs that are involved in migration, and whether these vesicles can be transferred to less migratory cells in this heterogeneous tumor that then affects the migration behavior of those cells. But in order to study this hypothesis, we of course had to first identify those cells that have taken up extracellular vesicles in order to study their behavior. And for that, we used the Cree-Loxp system. So first, we labeled highly malignant breast tumor cells with a CFP and with a Cree recombinase. And then we labeled less migratory breast tumor cells with a DS-RED roadblock, which was placed in front of GFP. So normally these cells express TD tomato or DS-RED, but upon Cree-mediated excision of this DS-RED roadblock, GFP is expressed. And we hoped to then be able to discriminate between cells that did not take up vesicles, the DS-RED positive cells, and the cells that did take up vesicles, the GFP positive cells. So what we first did is we characterized the vesicles that are released by these CRE positive cells. So we cultured them and we isolated vesicles from the supernatant by differential centrifugation. When we looked at extracellular vesicle markers such as CD63 and heat shock protein 70, we indeed could identify these markers in the extracellular vesicles. However, we could not detect CRE protein in vesicles secreted by CRE positive cells. But when we then looked at the RNA level by RT-PCR, indeed we observed CRE RNA being present in vesicles from CRE positive cells. So then we tested the system in an in vitro co-culture system. So we mixed the highly malignant CRE and the less malignant reporter cells. And only in the condition, in the mixed condition, we observed the appearance of these GFP positive cells, which were not present in the reporter only condition. And the appearance of these GFP positive cells was dependent on the ratio of CRE over reporter cells. So the more CRE positive cells in our culture, the more reporter cells we observed. Importantly, the appearance of these GFP positive cells was not mediated through cell-cell fusion because we did not detect CFP fluorescence in our GFP positive cells. Moreover, when we used a transwell system in which only vesicles could go through the transwell, we only observed the appearance of GFP positive cells in the condition where we seeded CRE positive cells in the upper well of the transwell system. So this is all, of course, nice, but it's all in vitro. So we wanted to study whether indeed vesicles are also taken up in an in vivo setting. So to study that, we injected these less malignant reporter tumors. When the tumors were full blown, we injected extracellular vesicles that were isolated from CRE positive cells, and in addition treated with RNase and proteinase K to degrade potential RNA and proteins that were still on the outside of the vesicles. And indeed, we observed the appearance of GFP positive cells, which was not the case when we either injected non-vesicular recombinant CRE protein or when we injected lysates from CRE positive tumors, really indicating that our method reports the uptake of extracellular vesicles from CRE positive cells. So now we also wanted to investigate the extracellular vesicle release in an in vivo setting. So what we did is we co-injected the highly malignant CRE cells and the less malignant reporter cells in the same mammary gland. And also here we observed the appearance of these GFP positive cells, which is even better visualized in this intravitally imaged tumor, where you here in blue again see the highly malignant CRE positive cells, and in green the less malignant cells that took up vesicles from these highly malignant cells. And also in vivo, the appearance of GFP positive cells was not mediated through cell-cell fusion because we did not detect CFP fluorescence in the GFP positive cells. Then we did a very striking experiment. So we decided to inject the highly malignant CRE cells and the less malignant reporter cells physically separated, so in opposing mammary glands. And also in this condition, we observed the appearance of GFP positive cells, really indicating that these highly malignant CRE cells release vesicles that are then systemically transferred to distant sites in the body. But this might also indicate that non-tumor healthy cells elsewhere in the body might be taking up vesicles released by tumor cells. So to investigate this, we injected melanoma CRE cells in syngenic mice, and these are reporter mice. So they have a lock-stop-locks TD tomato construct. So basically, normally all the cells in this mouse model are non-fluorescent, but upon CRE-mediated recombination, TD tomato is expressed. So when we looked in the direct tumor microenvironment, we indeed observed the appearance of these TD tomato positive cells. And also when we looked at distant organs, including the lymph node, the lungs, and the spleen, we observed the appearance of these TD tomato positive cells. So we had an initial look at what these cells are, and these include both non-immune cells because they're CD45 negative, but also immune cells which are CD45 positive. And of the immune cells, we could identify some macrophages, F480 positive cells, and neutrophils, GR1 positive cells. So these results, I think, change the whole concept or add another layer to the concept of intercellular communication, because normally we used to think that cells communicate through growth factors, for example, released by cell A, and that bind to a receptor on cell B, and that changed the behavior of cell B. However, now we also showed for the first time in a physiological context that cells also release vesicles that can be taken up by other cells. And as with growth factors, extracellular vesicle-mediated communication may have various effects, including opposing effects. And it is known that vesicles can contain many functional biomolecules, including DNA, RNA, and proteins. So we were wondering, because we already know that the extracellular vesicles from these highly migratory breast tumor cells contain messenger RNAs that are involved in migration. And we were wondering whether upon uptake by less migratory cells, whether there's an effect on migration of these cells. So in order to investigate this, we again co-injected the highly migratory Cree cells together with the less migratory receptor cells, and we performed intravital microscopy to characterize the migration behavior of the cells that did take up vesicles and the cells that did not take up vesicles. So obviously the migration behavior of the highly migratory cells is more, they migrate more than the less migratory cells. But when cells take up vesicles, they start to increase their migration behavior, as you can better see in this graph over here. We characterized many different mice and many different microenvironments. And although the basic level of migration differs a bit depending on the mouse and the microenvironment, the migration speed of the GFP positive cells in the same microenvironment is always faster compared to the migration speed of the cells that did not take up vesicles. This was true for both the local communication experiments, where the highly malignant Cree and the less malignant tumor cells were mixed, but also true for the distant communication experiments, where the tumors are physically separated. So then we were wondering whether malignant extracellular vesicle uptake induces migration, or whether it's that the migratory cells take up more vesicles. Well, several experiments exclude the latter hypothesis because in vitro we do not see a relation between migration speed and the ability to take up vesicles. And in vivo, if there were to be a correlation, it would be an inverse correlation, meaning that the less migratory cells take up more vesicles. So it looks indeed like the malignant extracellular vesicle uptake induces migration. So then we were wondering whether also the inverse is true. So what happens if we inject less migratory Cree cells together with more migratory reporter cells? So again, we did similar experiments for intravital microscopy to characterize the migration behavior. And in this case, the cells that report vesicle uptake have a lower migration speed to the cells that did not take up vesicles. So indeed, again indicating that a transfer of extracellular vesicles phenocopies behavior from the donor to the receptor cells. Well, since migration in the primary tumor is closely correlated with the capacity to form distant metastases, this is also something that we wanted to investigate. So we quantified the ratio of green over red in the primary tumor and in the lung metastases. And if there was no increase in metastatic potential, you would expect that this ratio equals 1. So when we characterize cells that took up vesicles from less malignant cells, we observed a small but statistically insignificant decrease in the fold metastatic potential. However, when cells take up more, vesicles from more malignant cells, we see a huge fold increase in the metastatic potential, both for the local communication experiment and for the distant communication experiment. So this brings me already to my conclusion slide. So I hope I've convinced you that we can now, for the first time, observe extracellular vesicle transfer between tumor cells and between tumor and healthy cells. This happens both locally within the same tumor and systemically. And when we think about some clinical observations, when you remove the primary tumor, there can be three outcomes to the distant metastases. So either nothing happens, the metastases shrink, or they suddenly start to progress, they start to grow. And these effects, these mechanisms were unknown, at least for a large part, but at least one of the underlying mechanisms might be mediated by extracellular vesicle transfer communication between those two different sites. I hope I've also shown you that functional behavior can be phenocopied through the transfer of extracellular vesicles. And in the case of the transfer of malignant extracellular vesicles to less malignant cells, this increases the migration and metastatic capacity of those cells. With that, I would like to almost end. I would just like to say that currently I'm in the lab of Professor Joanna Joyce at the University of Lausanne. And as you may know, she is an expert in the field of the tumor microenvironment. And in her lab, I'm now studying the role of the tumor microenvironment in adult brain cancers, both during tumor progression and in response to therapy. And also for my next career step, where I will move back to the Netherlands, I'm planning to use intravital microscopy in the context of also the tumor microenvironment, but in that case, in pediatric brain cancers. With that, I would like to thank the lab where I did my PhD, at the lab of Jacco van Renen. I had an amazing time in this lab, and I really would like to thank Jacco for his past, but also his ongoing support for my career. And with that, I'm happy to take any questions.
Thank you very much, Anoek. Very cool. So we have a set of questions. Okay, there was one that I could not really understand, so I asked Gamal Akabani to rephrase a little bit. So she or he, sorry, I recall where EV and other growth factors shed by tumors have a self-positive feedback for tumor migration and invasion. So it's basically asking whether this can have some sort of an autocrine signal, the EVs.
Whether it's amplifying basically the speed of tumor progression.
Yeah, I guess so. Yeah.
Yeah. So that is the beauty of the system, but also the disadvantage of the system. We are only looking at one part of the communication loop, of course, because we also know that the less migratory cells also release vesicles that are also taken up by all cells in the microenvironment. So the net effect is a bit hard to predict, at least in the system that we used. It can be that more migratory cells release more vesicles. So in that sense, that it's still the net effect is that the tumor progression goes faster. But this is some speculation. This is difficult to tell. But indeed, you know, it's never only uptake from more migratory cells. We have to consider that there's also uptake from less migratory cells.
Okay. Then there's a question from Louisiane. She wants to know whether you've used the intravital imaging window for the small intestine and whether this could lead to some issues caused by peristaltic movements of the gut.
Well, I personally assisted in some final experiments for a manuscript that had to be finished around the time I was in Jacco's lab, so I used it a couple of times. I must say, yes, sometimes we have difficulties with peristaltic movements, and we tried several things to reduce that. One of the things we tried is to fast the mice a couple of hours before the intravital imaging experiment. That it didn't seem to have an effect. So in the end, so sometimes we were lucky. We had not a lot of peristaltic movements. What also helped a lot is to use the resonance scanner for these type of experiments. So you just go super fast, basically. You scan super fast, and that helped a lot.
Then we have two sets of questions. Maybe I will keep the one from Roberto for the roundtable. I will ask the one from Takashi Nishina, which is one question that shakes a little bit the EV field always, is how many EVs would be taken up by other cells? And have you checked whether EV transfer to normal cells also change their phenotype?
No, so that is a super interesting question, but it was outside the scope of what I've been doing. But it is definitely a super interesting question, what it does to the healthy cells. How many cells are needed, or how many vesicles are needed to really change a phenotype? That is of course super hard to answer, especially in our experiments, because we had a bit of so when we used in vitro isolated extra vesicles, we always had the feeling that they were less efficient in mediating the phenocopying compared to the in vivo situation. We now think, because later on we started to use different methods to isolate the vesicles, and we think that by ultracentrifugation the vesicles, you damage at least part of the vesicles, and you change the natural properties, which also probably affects their uptake and the capacity to have an effect. Another thing that we need to consider is when you add vesicles, and you can really then of course quantify the amount and start to understand how many vesicles are needed to mediate a certain effect. We have to take in mind that this is always just a one time point that you dump a lot of vesicles on the cells, but that's it. Whereas in a natural condition, the cells continuously release vesicles and there's a continuous uptake. So whereas the question is super interesting, I think the methods to study this are currently lacking. Yeah.
So we're moving to Kendelle Murphy. She is at the Garvan Institute in Paul Timson's lab, and she obtained her bachelor degrees at the University of Western Australia, and then completed her honors degree at the Garvan Institute. And so she actually received recently, in 2020, sorry, her PhD at the Garvan Institute under the supervision of Paul Timson, and this is what she will tell us about. She's currently still a postdoc in his lab. She's using this famous intravital imaging technology to expand on her previous work in pancreatic cancer, and studying how the surrounding microenvironment actually influences invasive and metastatic capacity of pancreatic cancer. So I won't go further in the details of that, because this is what she will tell us today. I just want to mention that I was very lucky to meet Kendelle, and she was very nice with me when I spent some time in Paul's lab. Which I really appreciated. And thanks for joining, Kendelle.
All right, I'll just make sure this is sharing okay. Is that okay for everyone?
Yes.
Yeah. All right. So thank you firstly for the opportunity to present some of my work to you today. And as Jackie said, this is what I've been working on for the last few years during my PhD. And it's really about how we've used intravital imaging to complement some of our in vitro experiments, particularly in pancreatic cancer, and how we can try and personalize this to individual patients. And it's not going to let me go to the next slide. There you go. So we know that within pancreatic cancer, as the tumor progresses from a normal pancreas through pan-in stages to full-blown PDAC, we get a marked increase in the deposition of ECM components and this really fast fibrotic reaction, which we all know drives tumor disease and development, and also has an influence on response to therapeutic intervention. So what we wanted to see if we could try and manipulate this and modulate it to try and improve chemotherapy within the clinic. So to do this, we wanted to see if focal adhesion kinase levels also increased and changed over the course of disease development. And what we saw is that yes, both total FAK and also levels of active FAK increased through disease. So here we took this as a way to try and target this fibrotic reaction. And what we know is that these levels increase not only in the stroma, but also in epithelial cells. And what was really interesting is that if we take patient samples from people who have received no treatment prior to surgery from the ATMA cohort and compare them to samples taken from patients that received chemotherapy prior to surgery, we can see this marked increase in the fibrotic reaction. And this keeps continuously circling in a feedback loop, continually trying to hamper therapeutic intervention and also further driving disease progression. Now, what we've really focused on throughout my PhD is trying to uncouple the difference between epithelial and also stromal targeting. So when we take patient samples from the APGI cohort, look at microarray expression or patient-derived xenografts or even TMAs, we can really see if there's a difference in the survival in these patients. So for example, if we took bulk tumor sequencing from the microarrays of the whole tumor, as you can see here in red, in patients that have high FAK levels, they have a poorer survival. And what was really interesting is that when we used analysis of the tumor microarrays, pulled apart different markers such as fibrosis and FAK, if we took a subset of patients that had lower levels of fibrosis, so in early disease development, those with high levels of active phospho-FAK had a poorer prognosis than those with lower levels. And this to us highlighted a subset of patients which may actually benefit from treatment regimes. So the bulk of my PhD focused on trying to uncouple the epithelial and stromal targeting benefits within pancreatic cancer. So to do this, I used organotypic matrices, which if anyone knows Paul probably knows about these, where we allow fibroblasts to contract the matrix over a 12-day period. So they remodel this and cross-link the collagen, making it smaller before we seed cancer cells on top. Once the cells have adhered to this and started to proliferate, we then move these onto a grid, creating an air-liquid interface and chemotactic gradient to which the cells invade. Now, this actually really lets us to uncouple the benefits of targeting the stroma or the epithelia, or in a chronic setting where we can target both. So if we look at targeting only the epithelial aspect of this experiment, where we treat with our FAK inhibitors only during invasion, we can see that when we use KPC cells, the highly invasive model of pancreatic cancer, there's only a subtle reduction in cancer cell invasion. However, if we switch this up and start to target the stroma, where we treat the fibroblasts during the remodeling phase, inhibiting their ability to remodel and contract the matrix over 12 days, as we can see here, we have a dose-dependent response where by treating with our FAK inhibitor, we see a marked reduction in collagen contraction and an increased size of the matrices upon treatment with FAK. When we looked in the microscope at second harmonic generation and the levels of cross-linked collagen within these matrices, we saw that our FAK inhibitors, as we expected, were reducing the amount of fibrosis within these matrices. If we then take our KPC cells, seed them onto these contracted, or in the case of the FAK inhibitor matrices, not very well contracted matrices, move these onto grids and allow the cells to invade, what we see here is that this priming regime, as we call it, or stromal targeting, significantly reduces KPC cell invasion into these matrices. And what was even more interesting is that if we did a chronic treatment regime where we targeted both the stroma and the epithelial compartment, this offered no benefit over our priming and stromal treatment only regime, which means that we can use less drug to try and have an effective response in pancreatic cancer. And if we then add in our clinically relevant chemotherapy, gemcitabine and Abraxane, into this priming regime where the matrices are no longer remodeled, we see a marked increase in cell death in our KPC cells upon treatment with gemcitabine and Abraxane. And in parallel, we also see a significant decrease in the proliferation of cells treated with gemcitabine and Abraxane if these matrices have previously been primed with our FAK inhibitors. Now, how does this tie into intravital imaging? Because obviously here we can quite easily pull apart the two different compartments, which in a live native tumor isn't so easy. So to do this, we wanted to just first of all see if our FAK inhibitors were working. So within our intravital microscopy unit, we're able to visualize not only our cancer cells, but also the second harmonic generation and collagen. And also we use quantum dots to visualize the vasculature. So just to verify that our drugs are doing what they should, we performed simple skin flap surgery. Once the tumours were developed, we treated our mice with our FAK inhibitors, and a couple of hours later, following surgery, we intravitally imaged the FAK biosensors which we'd utilised in these cells. And as we expected, in our vehicle conditions, FAK was highly active in these tumours. However, when we treated these mice with our focal adhesion kinase inhibitors, as we hoped, FAK was rendered inactive. Now, we wanted to take this sort of priming regime a little bit further. How can we take this regime where we try and pre-treat the tumours to try and disrupt the fibrotic reaction that we previously saw, and then treat with chemotherapy? Can we improve this chemotherapeutic response? So to do this, we once again injected mice with KPC cells. This time, instead of expressing the FAK biosensor, they expressed the Fucci cell cycle reporter. Once tumours were developed, we pre-treated these mice with our FAK inhibitors, gave them a little break before treating them with chemotherapy, and after 24 hours, performed skin flap surgery to image these tumours. Now, we first looked at the levels of collagen within these tumours, and as we can see here in our control and chemotherapy only settings, there's a large fibrotic reaction within these tumours. Now, it's not full fibrosis. These tumours are only 9 days old, so it's only a little bit. However, when we treat with our FAK inhibitors alone or prior to chemotherapy, there's a marked reduction in this fibrotic reaction. If we then switch and look at the Fucci cell cycle reporter within these cells, in our control cells, they're red and quite actively dividing. Chemotherapy is effectively stalling the cells in G2M. And what was really interesting is that with our FAK priming regimes alone, we saw a switch of KPC cells from the red to the green, with the cells stalling upon treatment with FAK inhibitors alone. Now, this stalling rendered the cells further more vulnerable to subsequent chemotherapeutic intervention. As we can see here in our combination treatment, and almost the entire tumour was arrested in G2M. Now, in order to try and uncouple exactly what was happening here, we switched back to some in vitro experiments. And it was in collaboration with Thomas Cox at the Garvan Institute. We used his polyacrylamide gels, which are a stiffness tunable matrix, where we can try and manipulate the stiffness of these tumours and see if the switch that we saw with our FAK inhibitor treatments alone to G2M was due to changes in the fibrosis of these tumours and the stiffness of these tumours. So here we took two different gels, one that was quite stiff and one that was quite soft, but that both had identical overlays of collagen. When we then seeded KPC cells expressing the Fucci cell cycle reporter onto these, and wanted to see if by changing the stiffness of the matrix which the cells were seeded onto, we saw a change in the cell cycle. So I apologize for how confusing this slide possibly is, but I'll walk you through it. Now, in our stiff matrix condition up the top, what we see is that most of the cells are actually in G1 phase and dividing. And when we added our FAK inhibitors on top of this, there was no change in the distribution of cells in different phases of the cell cycle. What was really interesting is that on the softer gels, when we compared this to the stiff gels, we saw a shift in the distribution of cells in G2M. And when we add our FAK inhibitors on top of this, this doesn't change, which suggests that it wasn't necessarily the FAK inhibitors themselves that were shifting KPC tumours into G2M, but rather the changes in the fibrosis and the stiffness of these tumours that then rendered the cells more vulnerable to subsequent chemotherapy. And just as we saw in the tumours, when we added chemotherapy onto these gels, we saw that on the stiff matrices, yes, it was arresting cells in G2M, but this was even further enhanced on the softer gels. And when we add the FAK inhibitor in as well, it's no further enhanced. So as we expected, it's not necessarily the inhibitors themselves that were arresting the cells, but rather the stiffness of these tumours. Now, we wanted to look not only in the primary tumour, but because pancreatic cancer is a highly metastatic disease, we wanted to also look at some of the cells in transit and also the establishment of secondary lesions within the liver. So to do this, we first used intrasplenic injections where mice were pre-treated with our FAK inhibitors prior to, the day of, and the day after injection. They were then given a small holiday before 3 days treatment with chemotherapy. 24 hours after the last treatment, we ex vivo imaged the livers. Now, what we saw just by looking at the livers alone was that FAK treatment by itself or prior to chemotherapy significantly reduced the number of metastases in these mice. Now, this is really quite promising given how metastatic the KPC model can be. And as we can see here, just by simple H&E analysis, there's considerably less metastases upon treatment with FAK inhibitors. What was also really interesting is that these metastases are also considerably smaller than in our controls and chemotherapy alone. Now, did chemotherapy really work better? Well, once again, we used the Fucci cell cycle reporter to answer this question. And as we saw in our primary tumors, there's large metastases which are rapidly dividing and growing. Chemotherapy is stalling cells in G2M. And quite interestingly, just as we saw in the primary tumor, when we've primed these mice with our FAK inhibitors, it's not just the primary tumors that show a slight shift to G2M phase with our FAK inhibitor, but also the metastases. And when we then add chemotherapy onto this, we can see a really quite vast shift where almost all the cells in the liver metastases have shifted to G2M. So what we know from this is that by priming our mice and pre-treating with our FAK inhibitors, we can stall cells in G2M and render them vulnerable to subsequent chemotherapy. But how does this affect the cells when they're transiting from the primary tumor to the liver? So we did some quite simple anchorage-independent growth assays. And what we see is that when we treat these cells with our FAK inhibitors, there's a marked reduction in not only the number of clusters, but also the size. And we just wanted to see if we could do it to begin with, but we decided to put the cells expressing the FAK biosensor into these AIGs and see if we could image the cells in suspension. And what we saw here is that, yes, our FAK inhibitors are significantly reducing FAK activity within these cells in suspension. And so what we believe is that by inhibiting FAK prior to chemotherapy, we're reducing FAK activity and then preventing the successful landing of these cells. Now, to actually look at this question, we performed some simple shear stress assays. And what we did here was we pre-treated our cells with FAK inhibitor prior to exposing them to 5 passages of shear stress through a needle at a defined rate and speed. 24 hours following shear stress, we then used FAK sorting to simply see if we were enhancing cell death in our FAK primed cells. And what we saw was that if we pre-treated our cells with our FAK inhibitors prior to shear stress, we could significantly increase the rate of apoptosis within these cells, suggesting that what we see is that our cells in transit are less treated with FAK inhibitor, are less active, also more vulnerable to the shear stress forces. And when we then take cells that have been pre-treated with FAK inhibitor and put them through shear stress, following that, we put them onto our organotypic invasions. What we see is that over 7 days and also over 14 days, if we take cells that are pre-treated with our FAK inhibitor, we can actually significantly reduce the landing, adherence, and also invasion at secondary sites. So what we've seen here is that by pre-treating the mice with our FAK inhibitors, we can affect multiple aspects of metastasis, from not only the cell's survival within a anchorage-independent setting, but also upon landing at secondary sites and adherence and colonization of these sites. Now, the other aspect of my project is to look at the personalization of medicine. As we all know, no 2 tumors are alike and no 2 patients respond to a therapy in the same way. Whilst one might have a high fibrosis in the tumor and low Merlin, for example, there might be another patient that's got a low fibrotic reaction, but also high Merlin. Now, this is clearly going to affect the way that each individual patient responds to therapy. And what we've been working on in the last half of my PhD is to really try and isolate a subset of patients that are likely to respond to our FAK priming regimes. Now, to do this, as I mentioned before, if we take patients that have early low levels of fibrosis and then also look at their levels of FAK, we know that if patients express high levels of phospho-FAK, they exhibit a poorer prognosis. So what we wanted to do is to see if different tumours had different responses to our FAK priming regimes. So to do this, we collaborated with the APGI cohort and analysed the panel of cell lines for different levels of FAK. From here, we chose two different cell lines, the TK5s, which had high levels of FAK, but very low FAK activities. And then we took a different cell line, the TK10s, that exhibited high levels of FAK, low levels of FAK, but exceptionally high levels of activity. And we verified this by phosphotyrosine-enriched mass spectrometry and also by Western blot. And what we wanted to see first was how these cells responded quite simply to our FAK inhibitors. Now, if we take the FAK biosensor, put it into these cells, and then watch their response to drugs, to our FAK inhibitor in real time, we can see that TKCC5 cells, as we saw before, have very low active FAK, which can't be lowered any further upon treatment with our FAK inhibitors. However, if we take out TKCC10 lines, they have incredibly high levels of active FAK, which we could significantly decrease upon treatment with our FAK inhibitors. Now, we wanted to take these two cell lines and see how they responded to our different treatment regimes. Do they respond to epithelial treatment, priming treatment, or chronic treatment, or none at all? So if we take our TKCC5 cell line, which had our low active FAK levels, and look at treatment through only the epithelial aspect of an organotropic invasion assay, we see that our treatment has no significant influence on the invasive capacity of these cells. However, what was really quite striking is if we'd manipulated the matrix prior to seeding these cells onto them and allowing them to invade, we saw this marked decrease in cell invasion into the matrices in both the primary and chronic setting, suggesting that whilst these cells may not benefit from a later targeting of the epithelium, they will respond to subtle manipulation of the fibrotic stromal matrix. Now, if we get our TKCC10 cells, which responded to our FAK inhibitors as we visualized by the FAK biosensor, we can see here that when we treat during the late invasive stages, the FAK inhibitor significantly reduces cell invasion into the matrix. And if we've pre-treated these matrices with our FAK inhibitors, as you can see here, this priming regime also reduces TKCC cell invasion into the matrix. So unlike the TK5 lines, these cells seem to respond to both epithelial and to stromal targeting. So if we then take these cells, put them into the mice in a survival experiment where we orthotopically inject them into the pancreas, then once the tumors have developed, we prime these mice with our FAK inhibitors before they're exposed to two individual treatments of chemotherapy. And we repeat this treatment cycle until endpoint. Now, if we take our FAK insensitive line, the TK5s, we can see that FAK alone has no benefit on survival. Chemotherapy works quite amazingly, surprisingly. And when we added in our FAK inhibitor, it offered no benefit upon chemotherapy treatment alone. However, what was quite interesting and we weren't particularly expecting was that when we looked at the time and to metastasis within these mice, once again, FAK treatment alone had no response. Chemotherapy delayed the onset of metastases. But if we treated this previously insensitive line with our FAK inhibitors prior to chemotherapy, we saw a delayed onset of metastases within these mice. However, when we looked at our FAK sensitive line, the TK10s, we see that FAK inhibitors alone have a significant influence on the survival of these mice. Once again, chemotherapy works quite well. And when we pre-treated the mice with FAK prior to chemotherapy, we again saw an enhancement in survival. And what was really promising is when we looked at the metastases in these mice, whilst we know that our FAK inhibitors delayed the onset and also the number of mice with metastases, chemotherapy had similar results. If we'd primed these mice with FAK inhibitors prior to chemotherapy, there was a marked reduction in the number of mice with metastases and also the number of metastases themselves. And whilst we saw that 50% of the mice still had metastases, there was often only one single metastasis on the liver, suggesting that we've now isolated a particular subpopulation of patient tumours that can respond to our FAK priming regimes. Now, I apologize, there's not as much intravital imaging in this section. It's a little bit more personalized medicine, but nonetheless. We also then wanted to see if there was other biomarkers that we could use. Sometimes one biomarker isn't enough and we need a companion biomarker. So it's recently been noted that in mesothelioma, Merlin levels predict for response to FAK inhibitors. So Merlin's involved in cell junction signaling, and in cells with high levels of Merlin, they rely on the connections between the cells. However, in cells with lower levels of Merlin, they have a higher reliance on cell signaling between the ECM and the tumor cells, which renders them more sensitive to FAK inhibitors. So when we looked at our two lines, as we predicted, the TKCC5s, which don't respond to our FAK inhibitors, had super high levels of Merlin. However, our TKCC10 cells had exceptionally lower levels of Merlin, suggesting that this could be an extra biomarker and also be a reason why our TK5s weren't responding to our FAK treatments. So we took these cells, knocked down Merlin, and then wanted to see our response, the response of these knockdown cells to our FAK priming regimes. So what we did here was we subcutaneously injected these cells into mice, pre-treated these tumors with our FAK inhibitors prior to chemotherapy. And over a 28-day period or 2 treatment cycles, what we saw was that in our control setting, FAK inhibitors alone had little effect on the overall size of the tumors. Chemotherapy slightly reduced growth, and pre-treating these tumors with our FAK inhibitors had no real improvement over chemotherapy. But what was really promising is that in our knockdown lines, our pre-treatment regimes with the FAK inhibitor priming prior to chemotherapy significantly reduced tumor growth. So I know this graph is considerably more confusing than it needs to be. However, if we just focus on this bottom line here, we can see that in a previously insensitive line, by knocking down Merlin and pre-treating these cells with FAK inhibitors prior to chemotherapy, we've now managed to successfully stabilize disease. Now, what does that mean for our patients? Well, when we take some more samples from the APGI cohort and have a look at the bulk tumor, we know that in sample patients with low Merlin levels and high phospho FAK, that this is predictive of a poor survival and prognosis, and that these particular patients may actually benefit from our FAK priming regimes and improve survival within this disease. So I hope that I've shown you a little bit of the insight into my PhD. And again, I apologize for the lack of intravital imaging and slightly more in vitro studies. However, we've managed to look at how our FAK priming can reduce cell invasion, reduce metastases within these mice, reduce the survival of cells in transit, reduce matrix remodeling, how this disrupts the cell cycle, rendering cells considerably more vulnerable to subsequent chemotherapy. Now, I'd just like to thank everyone in my lab for supporting me for the last 5 years, particularly Paul for putting up with me this whole time, and also everyone else who's helped with this project and all our funding bodies, and to everyone for listening today.
Thanks a lot, Kendelle. Am I back? Because I lost you. I'm here. Yeah, sorry. I had a few cuts. That was amazing. So very comprehensive story, which is very cool. So I don't see at this moment any open question. So if you guys have question, there's one from Gabal Akabani. Excellent work. So FAK is an invasive protein. Is it general to all solid tumors? I guess the question is, does FAK inhibition apply to other tumor types, other solid tumors?
Yeah, it can. It's well known to be activated and overexpressed in multiple other cancers, not just pancreatic cancer. So there's actually quite a few studies in solid cancers where they're trying to use FAK inhibitors in the clinic to see how tumors are responding. So yes, it is a highly invasive protein, and it's well known to have roles in cancer invasion, migration, and also, like I said, signaling between the ECM and the tumor cells.
Cool. So there's a question from Anoek. and she wants to know, well, Anouk, do you want to ask the question yourself?
Yeah, sure. Yeah, great talk. Thanks. Yeah, I was wondering, I was intrigued by this fibrotic response that you observed in the context of chemotherapy. And I was wondering, do you know what is the origin of this fibrotic response? Or is it the cancer cells, or is it like stromal cells or vascular cells that expand, or do you know anything about that?
At the moment, we haven't looked into what's causing this response after chemotherapy. Our current theory or hypothesis is that's from the fibroblasts. However, these are only recent samples that we've come across, so it's something that we are currently looking into, and hopefully we'll be able to work out why this fibrosis is just continually getting worse every time patients are treated with cancer, because in theory, treated with chemotherapy, because in theory, the chemotherapy should effectively kill cancer cells and obviously some of the fibroblasts, but there's still this reaction happening. And when I have looked at them, there's a vast number of cancer cells that are dying and dead. However, there's still fibroblasts that you can see within it. So that's where our theory is coming from, but it's something we're still looking into.
Yeah, actually, if I can go on into this, the fibroblasts would be more resistant to the chemo because they are not proliferative. So that could be the reason why they're expanding.
Yeah.
I wanted to ask you the question on the first part. So did you look at the metastatic site, the liver, for example, if there are differences in stiffness before cancer cell arrive or before your treatments or post-treatment?
We've not actually looked at the stiffness in the liver itself. We are starting to look into the metastases and seeing if there's different amounts of collagen within the individual metastases, but we've not looked at the liver as a whole and changes in stiffness with just our FAK inhibitors alone. That would be something that's really interesting to do in the future.
And have you tried to probe whether the FAK inhibition really does reduce the stiffness of the stroma? Because you have some sort of correlation results when, like playing with stiffness, you have an effect on the cell cycle. Yeah,
so we haven't done it with the tumor samples. We have done it with the organotypic matrices, and we do see a reduction in the stiffness upon treatment with our FAK inhibitors. So that's where we've started to look at it, and we're actually going to go back and have a look at the tumors as well and see, just to verify that it is that our treatment, whilst we know it's reducing the levels of cross-linked collagen by SHG, we want to test using our in-house rheology if it is changing the stiffness as well.
Maybe Daniela, you start. There were, I think there was a question for no?
Yeah, I have a question from Giorgio Siano to Roberto. Do you think that some macroscopic regional cofactors like compression or stretch may induce or increase tumorigenesis in your model?
It is a possibility. The question is how to assess that using Intravital. You need to have the right probe to see whether you can measure compression or stretch in those tumors and then make the correlation. It is a possibility, definitely.
And there is a question for Anouk. I think it was the same question from me and Roberto, I think, a very similar one. I can ask my way. Did you consider that the normal cells would secrete some kind of EVs that would normalize or, let's say, inhibit migration of tumor cells?
Yes, we did that experiment actually. So we did the reverse experiment where we had a Cree expression in the complete mouse, ubiquitous expression, and we injected reported tumor cells. We do see uptake or we see switching, but it's not a lot of cells. So either suggesting that these tumor cells take up less vesicles, or whether healthy cells just simply release less vesicles. And that's why maybe if the highly migratory, highly aggressive cells release more vesicles, that this is the way that it also can speed up tumor progression. Yeah.
So I will say it my way, also a different variation on the theme. Granted that there are the issues in the purification, but have you ever tried to purify the extracellular vesicles from the less aggressive and inject intratumoral into the animal and see in an animal that has already the more aggressive tumor, to try to see whether that would work as a quote unquote therapy. I know it sounds a little bit weird, but.
No, the only experiment that we did in that regard is to co-inject these less migratory Cree cells together with the more migratory reporter cells. So indeed the reverse experiment, but we did not inject the vesicles, but we let them produce in vivo by the Cree cells. And indeed, in that case, we do see that there is less migration and less metastatic capacity of the cells that do take up vesicles versus the cells that do not take up vesicles. So that this indeed seems to be the case.
It would be great if you could do this exogenously. You purified a bunch of these exosomes on less aggressive cells and at least reduce the phenotype of the highly aggressive in situ. Because I can understand maybe in vitro this transfer doesn't work efficiently, but maybe when this happens in the environment, in the full environment, maybe there are higher chances.
Exactly. I think you need a continuous release and uptake in order for something like this to happen. Yeah, but I know that there are people indeed working on excellular vesicles as therapeutics. We did not investigate this further. And
these are classical experiments that are done in the context of metastatic priming, right? Where you subject the animals to exogenous injection of EVs. But I'm not sure what you suggest, Roberto, has ever been done of doing intratumoral injection of EVs. I'm not sure, but this would be interesting to check. So there was one additional question to Roberto also, and which is actually related to one. Maybe I ask mine first, and I will read the question while you answer mine. Is how do you do it? So it's a technique question. How do you do the correlation when you do the correlative imaging between intravital imaging and H&E staining? So there is histological staining.
So yeah, we start with the intravital imaging. So then the animal is euthanized, and the tongue is fixed either by intracardial or even direct, and is re-imaged again as fixed and do the same kind of, we know the area pretty much where the tumor is, then the tongue is embedded and is sliced extensively until you reach the area where the lesion is. And we acquire all this section, and then we match the section that we see with the optical slice that we have done with the Intravital. It's a lengthy procedure. This was just for having, you know, a lot of pathologists see these images and say, well, I don't understand what you are seeing there. Whether what if this is what is the classical definition of hyperplasia or dysplasia or carcinoma in situ or developing. So we had to, at least in a couple of examples, we don't do this routinely because otherwise that's will be all the time spent there, but at least to show that what we assign as a certain grade correspond to what is normally accepted with the golden standard.
Mm-hmm. So the question that Corinne Laplace had is, have you ever considered correlating this type of information that you get in this correlative imaging with a spatial, cellular, and functional mapping of the tumor microenvironment using mass cytometry, for example?
So this is what we are trying to do actually, is to start with the spatial transcriptomics. So at least in terms of gene expression, and now with the new techniques, and actually I think in few months it will be announced the complete cellular resolution. Right now it's 4 or 5 cells cluster on slices. So what we are actually doing is to section the tumor, take all this section and do the spatial transcriptomics correlating with the images. That will give just gene expression. So yes, there are other ways to do this through mass spectrometry that we are still exploring, but that's ultimately what we are interested in.
I think they decreased the resolution. There's a Cell paper that came out yesterday about spatial transcriptomics going down to micron-sized resolution.
Yeah, but apart from the paper, there are the company that is now ready to do it. So they are, at least they were a month ago, they were saying that they were going to release it soon. So apart from the paper, you need to have the support. That's the most important thing.
There is also a Roberto question for you from Colin Radcliffe. Very nice talk. Can you observe metabolic competition between the tumor cells and the host immune system? And do NADH levels in immune cells anti-correlate with levels in tumor cells?
We are looking into that. However, one of the things that we still don't understand why is that the overall level of metabolism in these neutrophils, at least when we looked, is much lower than what we see in the regular cells. And we don't know why. So this is something that we have to address differently. But yeah, that's one of the things that we are planning to do.
Do we have more questions, Jackie?
Yeah, I was a bit lost, but I think we went through most of them.
It was a question by Philip Carl to Kendelle. I think it was whether it's also true what you are seeing in melanoma.
Yeah, I think it just gave a confirmation that it actually also happens in
yeah,
there's
it's the same, very similar in melanoma.
Okay.
Oh, and I have a question here that I have seen in the chat to the panelists from Anoek. This is to me about whether our model metastatize. So yes, so actually if you use a wild type background without any other mutation, the system doesn't metastatize because the lesion become too big that we have to euthanize the animal because they are not able to feed even if they are on a liquid diet already. But we are switching to look at the metastasis to a model that is based on a SMAD2 knockout, or at least a conditional, and that accelerates the process rapidly, and that's where we ought to look at the metastatic process.
Yeah, super nice.
You had a second question, Anouk, you want to ask?
Yeah, it's whether I was wondering whether the migration of the tumor cells if you look at the migration at all, and if so, if the migration of the tumor cells at early stages of tumor progression correlates with the outcome, so stabilization of the decreased regression or growth.
We don't see migration.
Okay.
The cells are actually moving as a block at this stage, but because probably at the earlier stages it doesn't happen, they are still not free from the initial layer. So at least so far, up to 24 weeks, we haven't seen anything moving out.
Yeah, so maybe in the new
Yes, definitely.